and welcome to the NRMN Health Research Talk. I'm Ann Smith. Today I'll be talking with Dr. Stephen Olufemi Sodeke. Dr. Sodeke is a bioethicist and a professor of allied health sciences at Tuskegee University National Center for Bioethics in Research and Healthcare. Today he'll be talking to us about the informed consent process. What is informed consent? Why do the informed consent process? How can it be done correctly? And how will it help my research career? And Dr. Sodeke, welcome and thank you for being here.
Thank you very much. It's a pleasure for me to be here and to have this conversation with you. I have 3 slides that show all the documents that I used to prepare this presentation. And so this might be of interest to those that may be using it later on.
Yes.
These next 3 slides show those references that I have found helpful in trying to do this. Now, I'd like to cover 3 things during this discussion. I'd like to review the chief features of informed consent. I'd like to highlight the consent errors with the informed consent form and the process itself. And then I'd like to explain the improvement measures in engaging research participants with the informed consent process. So here's the first objective, the chief features of informed consent.
What is informed consent?
Informed consent is actually a very practical application of a principle for respect for person. Informed consent is a fundamental principle for ethical research involving human subjects.
So, and how can the principle of informed consent be justified?
There are actually 2 ways to justify the use of informed consent. One of them is the non-consequential argument that is grounded in the intrinsic quality of persons. That inherent need for self-determination, that personal interest, the preferences, the values, and the capacity for autonomous decision-making. And these are all consistent with the Kantian deontological theory that suggests that it is morally perverse to merely use a person as a means for others' ends. The other argument is the consequentialist argument, which grounds itself in the idea that the best action to take is the one that gives us the best consequences compared to other alternatives. For instance, if we have increased adherence to protocol, it suggests the interests of subjects are protected. Anything we can do to do that, or anything we can do to foster public trust, these are the kind of action that we should take. And informed consent is one of those that can be part of that sort of argument. Now, informed consent in practice, in the moral sense, is an autonomous authorization of one's participation in research, a morally effective authorization, if you will, made by a particular person that has a decision-making capacity, who has substantial understanding of relevant information, and who is free of controlling influences in making that kind of decision, at least in the moral sense. Now, in the social-legal sense, one could look at informed consent as a legally or institutionally effective authorization. The practices and conventions that make it socially or legally acceptable to use a person as a research subject. It includes things like the rules that guide such use, the regulations that must be obeyed, and the cultural and professional practices governing informed consent to research.
So what necessitated the idea of informed consent?
Well, interestingly enough, the idea of informed consent was born out of public outrage for atrocities that have been committed against research subjects during the research process in the past. And so we actually have some classic historical cases that I can call attention to here, one of which is the Nazi doctors' atrocities in using prisoners to do all kinds of horrific experimentation on these prisoners, such as dipping someone in ice cold water to see how long they could take it until they finally die. Such kind of horrific acts were labeled in the 1940s as war crime for the Nazis. And when that was discovered, all the doctors that were involved were brought into trial at Nuremberg. Now, the two slides that I show indicate a prisoner being experimented on, and the other slide shows a shot of the trial at Nuremberg. That trial was how we got the very first international, if you will, ethics of human experimentation. It's called the Nuremberg Code. I will say a little bit more on that later. But while all of these were going on, beyond Nuremberg, we also have the research abuses that were going on in the United States, such as the Jewish chronic disease hospital case in 1963. You familiar with that at all?
Tell me more about that.
Okay. This was a study that was done on chronically ill patients that do not have cancer, but they were debilitated anyway. But physicians who experimented on them actually injected live cancer cells into them, of course, without necessarily obtaining their permission. The idea then was to find out whether the live cancer cell will survive better in chronically ill, debilitated, non-cancer patients as compared to cancer patients.
It's awful.
Outrageous, isn't it?
Yes.
Yes. Well, the second one that I can call attention to is the Willowbrook case that happened between 1956 and 1971. The Willowbrook State School was a school that was around for children that had mental problems. And the only way that the parents could get them into that school to get help for them was to participate in a hepatitis study where the hepatitis virus was fed to the children, unbeknownst to the parents, of course, so as to find out whether vaccines can be developed once these children develop antibodies to the local strain of the virus, and whether that development of the antibody could actually work for any other strains. And then around 1966, Dr. Henry Beecher actually looked at about 50 unethical studies in major journals in the United States and found out that only 2 mentioned getting consent. And of course, the last one that I'd like to call attention to is the United States Public Health Service study of untreated syphilis in the Negro male at Tuskegee, Macon County, Alabama. That study went on for 40 years, from 1932 to 1972. The study was initiated by USPHS, and it involved some 600 men, 400 of which had untreated syphilis, and 200 or so were used as control. These men were never told that they had syphilis. They were just told that they had bad blood. And even when penicillin was available as a bona fide treatment in 1942 or thereabout, these men were specifically prevented from getting treatment. Now, in order to, the purpose of this study was actually to understand the natural history of syphilis in the body. This study went on for about 40 years until a gentleman by name Peter Buxton blew the whistle. And so the Associated Press got wind of this, and public outrage was actually what stopped this study in 1972. Of course, there were a series of hearings, and out of that series of hearings headed by Senator Edward Kennedy at that time came the Belmont Report. I'll say a little bit more about that. So the Belmont Report, which suggests that 3 things. 1, there should be respect for persons. Remember I said respect for persons is the fundamental principle, and the application of it is what informed consent is.
Yes.
2, informed consent. 2, beneficence, which translates into carefully looking at the risks and benefits of research, balancing the risk with the benefits. And then justice, making sure that appropriate people are actually represented in participating in the research. Here's a picture from the United States Public Health Study of Syphilis at Tuskegee. There is a gentleman there from, that's phlebotomy, obtaining his blood, and then of course they had to, in order to understand the natural cause, they had to do a number of tests. Test on the chest, test on the cerebrospinal fluid to see if the person had developed neurosyphilis, all kinds of things. Bottom line is, they never told these people if it was okay not to treat them. They never told them if they had syphilis. And so one could surmise that ordinary people will not knowingly risk their health for the sake of science without consent.
Mm-hmm. And penicillin was developed during this time period, but was withheld.
And when penicillin, you're remembering, and when penicillin was developed, the men were intentionally prevented from even being treated with penicillin. That's kind of like adding insult to injury, isn't it?
Mm-hmm. Yes, it is.
All right.
So why do the informed consent process?
Well, the informed consent process is actually a process that is central to the protection of human subjects of research. Its intent is that participants are comfortable after they understand what is going to be done to them, are comfortable in making a choice, comfortable with their choices, whether or not to participate, and can comply with it. And all of that I just said have now been codified. Codified means set into rules and regulations, right? I talked about the Nuremberg Code just a while ago that came out in 1949. The very first article of that code is voluntary consent is absolutely essential in any human experimentation, right? And then there were other 9 articles that sort of detail how that was supposed to happen. Then we have several others that followed all that. We have the Declaration of Helsinki. This was by World Medical Association that followed suit after that in 1964, explaining to medical researchers how they are supposed to apply this fundamental principle of letting people know what it is that they are going to do when doing any medical research or experimentation. And that has been actually modified in a number of ways that is beyond the scope of this discussion. In 1975, 1983, 1989, 1996. All right, so it has undergone a number of iterations there. The Belmont report was what I mentioned last time in connection with the USPHS untreated syphilis study in black men. That Belmont report came out in 1979. And one of the other things, apart from those 3 principles that I stated, respect for persons, beneficence, and justice, is the idea that there should be an independent body that oversees, that reviews all the research protocols. Now, the last bullet point on my slide is the IRB/IEC. These are just the bodies. IRB stands for Institutional Review Board, and IEC stands for Institutional Ethics Committee, right? Now, I also have their CIOMS guidelines. CIOMS is an acronym that means the Council for International Organization of Medical Sciences. This is an international ethical guideline for biomedical research involving human subjects. And the first one came out in 1993 and has undergone some iteration in 2002. Right here in the United States, we had the Code of Federal Regulations supported by the Department of Health and Human Services. 45 CFR 46 is Title 45 of the code, and Part 46 applies to human research subjects. The other document that is important to note is 21 CFR 46, 21 CFR 50. That's the Code of Federal Regulation that the Food and Drug Administration supports. Notice that they deal with food, ideas, and drugs as well. So they have their own stated ways in which if you're going to test any of these on humans, then there are specific guidelines to follow.
So what I've heard you say is that the informed consent process aims to explain to the potential participant what will be done in the research study so that the participant can consider it and voluntarily choose if they want to participate in it or not.
Yes. Absolutely. You got it.
Yes.
All right.
So how is this, what is the process? How is this done?
All right. Very well. That calls into question some of the elements, essential elements then of the informed consent documentation. So not only should the human subjects look at what they need to look at, think through it after they've understood the information, make a decision, as you have indicated, but then it has to be documented. Somebody needs to know and be told. So, there is a particular form that's called the informed consent form, which will consist of 8 different essential elements. The first one being things that regard what the research is about. In other words, there's a description of what the study is about in the language that the participant, prospective participant, will understand. And we have a series of problems with that still, and we'll get to that soon enough. Then there's a statement of no risks in statements of benefits, if any, because it's not all of these experimentation that has benefits for those who participate in the research. On the long run, it might help other people, but not necessarily the people that participate in the research. So it's important to state not just the risks that are known, but also the benefits that may accrue. It's also important to educate the participants as to whether there are alternatives. That means you don't have to do this. If you choose not to do this, here are some other alternatives that are available to you. Now, those alternatives too may have side effects. We just need to be honest about it. And then there's the issue of confidentiality. There's also the issue of compensation. There's issue of who to go to, who to tell, who to ask if there are any questions. And so all these needs to be stated in the form. It needs to be stated very, very clearly that the participants are participating voluntarily, and to clearly also emphasize if they choose to withdraw from this study, how they can withdraw, when they can withdraw from this study. All of these need to be stated on the form so that the participant can be fully informed as to what they are getting themselves into.
And then does the participant have to sign the form?
Yes, actually, the informed consent process now, we just talked about the form, what should be in the form. Now we're getting into the process, which is actually a dynamic process. It's not a one-time event. In fact, it's a collaboration between the subject and the participants and the investigators that are involved. Yes, signing the form is important, but it does not end there. In fact, there are times when it might not be desirable to sign the form. Okay, so there are cases like that. But what's important is that the participant understand very clearly what it is that's going to be done to them, and they're given the opportunity to decide whether or not they want that done to them. There should be evidence of conscientious planning on the part of the investigator with the participants, prospective participant involved in how this is going to work. It's a collaborative relationship that should be free of coercion or undue influence on the part of the investigator to the participant. Now, This needs to be consistently implemented. I mentioned consistent implementation because where we have the cases of multi-site studies, unless there is personnel that are alert, the implementation of the informed consent process may not be consistent. Some would do it correctly, others will not. Mm-hmm. And there are cases to illustrate that. And then there's complete documentation and verification, right? Because there are times when you have to sort of revisit, if you will, even the informed consent itself. Now, I've put some cases there that will illustrate some of this. Here is the first case.
So case study 1. An HIV vaccine study is being conducted in 12 sites in multiple countries. In this study, some participants receive the vaccine being tested and some receive a placebo. The placebo is an injection that does not have the active ingredient being tested to prevent HIV. The study requires regular visits to the study clinic for blood tests, as well as completion of questionnaires on life and risk behaviors. In the first 12 months after vaccination, a growing number of study participants report an increase in risk-taking behaviors. In the responses from the behavioral surveys, many of the participants state that they believe that the vaccine will protect them. Many of them also appear to forget that they could receive a placebo with no active ingredient. The problem is more severe at 4 of the sites. All of this is reported back to the Community Advisory Board.
Aha. So, that case raises a number of questions that is related to all the things that we just talked about. Now, let's just suppose that you are one of the community representatives that is to advise the researchers. How would you advise the research staff concerning participants' reported high-risk behavior? How would you do that?
Well, it seems that the participants aren't realizing or remembering or understanding that there are some with the vaccine and some with a placebo that does not have the vaccine.
Yes.
And that it does not prevent HIV. And they think that they're getting the vaccine and they're protected, but they're not. So that explanation at the front end perhaps needs to be stronger and then needs to continue throughout the study visits to the clinic.
Wonderful. That high-risk behavior should be brought to the attention of the research staff immediately so they can do something about it. And you did mention some of the things that they could do. Now let's just suppose that they are now about to enroll new participants. What kind of thing would you make certain for them to pay attention to and do?
I would recommend greater explanation at the informed consent process about the placebo, that they may not be getting any preventive health measures with that they may not be protected. And perhaps quizzing the participants or somehow getting an assessment of their understanding and comprehension of that they may not be protected, and perhaps doing it frequently at their ongoing study visits.
Correct. Now, those are very good improvement measures that might be made even in the design of future studies. Because unless somebody calls an attention to them, they won't. It's not natural to think ahead of time. And part of the reason we are doing this is to explain to researchers and investigators to look beyond the study and think through the sort of things that can come up. I have several slides of different kinds of errors, and we will get to that as well. That was a good one, wasn't it?
Mm-hmm, yes, it was.
Okay. Good. Want to move into the second objective, which is to highlight the different kinds of errors with the informed consent form and the informed consent process itself. These consent errors are not limited to the United States, by the way. These are worldwide, and they consist of 3 different ones. In these slides, I have divided them into 3. The first one being problems with the content of the informed consent form itself and the readability of that form. In other words, there might be jargons on there. Yeah, you may recall that I said the thing needs to be written in the language that the participant, potential participant, can understand, right? Because researchers understand their jargons, but not necessarily those that they are going to enroll. The second set of errors are errors in the use of the informed consent form itself. And then the third set of errors are universal errors in the informed consent process itself. So let's look at the very first set of errors with problems with the content and readability. Content, for example, number of study participants sometimes are not specified. Exact protocol title are not necessarily understood by the subjects. They don't have a clue as to what this is all about because of the way it was presented on the informed consent form. The actual study time can be quite ambiguous to the subjects. They don't know when it's going to start, when it's going to end. There's a risk that we said should be stated, and sometimes these risks are downplayed by researchers. Payment for travels are not specified. Daycare, completing the study visits are not listed, whether there are, we may recall whether there are any compensation to assist the participant, percentage, chance of even receiving study products versus other forms of treatments are often unclear, right? Remember, one of the elements is, what are the alternatives? All right, other than what we're about to test. There is ambiguity sometimes from inconsistent references to patients, to participants as patients, sometimes as volunteers, sometimes as people, sometimes as subjects, right? Problems with readability includes also alternative treatment risk and benefit that are not described in writing, but only explained orally during the recruitment process, right? Study participants are not updated with new safety information, even when this is triggered. Right? And then final informed consent forms may not even reflect required IRB changes. In other words, the Institutional Review Board may look at the informed consent and say, make these changes there so as to be consistent with all the elements that we have talked about. And in the rush to get the study started, the investigator or researcher may completely forget. So they are using old forms without the new changes that the IRB has recommended. Sometimes there's absence of line for dates to determine when the consent was obtained and when the study began. Those 2 dates are very important because you don't want a informed consent form that's showing that it was approved after the fact, right? So there needs to be these dates there. All right, so these are errors that has to do with readability and content. Errors in the use of informed consent form itself. Use of expired informed consent form has been noticed worldwide. Use of altered informed consent form that deviate from the approved protocol have been noticed. Incorrect or invalid form, especially when related studies are being conducted simultaneously, right? They mixed up the forms, all right? All those have been observed. Here are some universal errors in the informed consent process. Missing informed consent forms and signatures. Sometimes they can't find it. They filed it somewhere else, all right? And the signatures are not necessarily there. Any relative signature, when the requirement is for parent or court-appointed guardian or word of state. If somebody else's signature, they think is just as good if it's a relative. That should not be the case. It's the parent, court-appointed guardian, or word of state. And then signature of personnel, not directly even connected to the study, when in fact what is required is the signature of the investigator. Witness signing without observing the informed consent process. So somebody will sign as a witness of the process when in fact they haven't actually witnessed it. Witness may sign in places that are meant for legally acceptable representative. See, these are all worldwide errors. And I bring those things up to caution those that will find these interactions that we're doing about informed consent useful in doing their work. Here's another case study that may help drive the points home.
A 7-year trial of antiretroviral treatments for couples where one person is HIV positive is being conducted in multiple non-urban communities in Kenya, Malawi, Zimbabwe, and South Africa. The study will provide a range of medications for treatment of AIDS and opportunistic infections that are not presently available in the communities where the study is being conducted. Each site will have 10 to 20 couples enrolled in the study, which represents about 10% of those who are eligible to participate. Most of the medications that will be studied have been proven effective in other settings, and a few of the medications need follow-up care after the study is over. 2 of the most promising study medications are very expensive and are known to cause resistance to future use if the treatment is stopped or interrupted. The researchers who developed the trial have indicated they believe the price of the medications and availability of antiretroviral medications will increase greatly by the end of the study.
Okay. This case raises a number of questions as well. Now, imagine that you are a member of a community advisory group reviewing this 7-year antiretrovirus study. If the participants will have access to medications, but the rest of the community will not, what kind of concerns will you have?
It raises some concerns that so few, only 10% of the eligible members of the community can participate, and that there's an unfairness or inequity there, but also then that those who do participate and receive medications might be inclined or persuaded to share those medications. They may give them to friends or relatives or may try to sell them, and then would be reducing the dosage that they're supposed to be getting and not providing enough to those that get the medications.
Those are very good observations, very, very good observations. And I would only add that I would be concerned too that only 10% of the people who are eligible will actually have this drug. Now, having mentioned that, what further concern would you have about the ability of the participant themselves to participate? Would you be concerned?
There may be some concerns that if so few are participating, that it will be noticeable and perhaps there's some stigmatization in their participation, and that other community members wonder why they're participating in it and others aren't.
Correct. Would they also think that that is the only choice that they have, and don't even think that they can say, I don't want to be part of this? If there are only going to be so few people, what about the rest of us?
Mm-hmm. Yes.
How about that?
Yes.
Does that make sense? Yeah, because now we're thinking, are the researchers having an undue influence on these participants who may think that's the only choice that they have, that they have no other choice but to participate?
Yes,
So
and they'll get the medications for free that are otherwise expensive or not available.
Yep. So is that kind of undue influence here, and not helping them to understand, hey, you don't have to do this. Remember, we talked about one of the elements of the informed consent, give the alternatives, right? This is what we're testing, but here is the alternative. Or the alternative may be the standard of care, if any standard of care is available, right? But they won't even think, they being in the participant won't even think that they have that. Now, if the medications have painful or harmful potential side effects, how might that concern you?
Well, certainly the participants need to be informed about that and to be told that there may be harmful or painful side effects. And the researchers have to make sure that the volunteer participants know it and understand it and are ready to handle any painful or harmful side effects. And the researchers have to have then plans for what to do if there are those side effects.
Absolutely. Absolutely. No risk of any experiment is to be downplayed, because there is the temptation to do that, right? In order to get as many subjects or participants as. Now, do you think researchers have any responsibilities at all to the participants and to the community about access to these medications, particularly if the experiment comes out positive, right? What kind of responsibility do you think the researchers have?
It seems that they should plan ahead and work with the community or the pharmaceutical company or someone to be able to provide the medications more widely to the community and at an affordable rate. And if they know ahead of time that it's going to be expensive, and they know that some of them may cause resistance to the successful outcomes of the medication if it's stopped or interrupted, they need to plan ahead so that the medication can continue at an affordable rate for the participants and the community. That may be a challenge, but it seems like the researchers should try to make plans to do that after the study's ended.
Wonderful, wonderful. Yes, that's exactly what they should do. Planning ahead is the key here, right? And it can be done. There are just several different ways of trying to do that. It is important to make sure that there is help after the study and to make that plain. The last objective is the improvement measures that I'd like to explain here. And this is kind of a summary of the informed consent process itself. If we want to conduct it in an ethical fashion, these measures include the following: reviewing the protocol with study volunteers and assessing their comprehension. Right? These ideas have come up in the discussion that we are having. allow for adequate time to read and formulate questions. They may not have questions right away, but they may have questions later on. So you need to provide for that opportunity. The researchers do. Sometimes there are technical words in there, like placebo, for example. So it's a good idea to provide a glossary of research terms and even graphics sometimes, because pictures work better for some and others. We've talked about the idea of quizzes and questionnaires in terms of assessing the comprehension of the informed consent form itself. A fellow by name Willis talked about cognitive interviewing, the idea of explaining what is going to happen to the participant and have the participant saying it back. I say, tell me what you understand by what I just told you, and then watch. And that's an opportunity to correct whatever has not been understood or misunderstood. And then, of course, assessment instruments are out there to improve the process. There is need for consistent communication. I said sometimes this communication is not even all through, particularly when we have multi-site studies. The researchers, investigators sometimes seem to forget that there is a patient and volunteer bill of rights that demands that any alternative treatment be communicated, right? Verbal assessment and inclusion in the decision-making process is appropriate for minor children if children are going to be part of this. They are not to be seen and not heard. Mm-hmm. After all, we're going to do it on them. And just getting the parents' permission sometimes is not enough. They have to say, yes, I want to do this. I'm sure you are aware that some have videotape presentations of informed consent form for future references and for review, involving impartial witnesses in these, such as parents, guardian, and the review process, so that more than 2 ears can hear it and remember, and new information, if it ever comes up, need to be shared with the participants who committed to participate in the process.
So this informed consent process is important and very involved, and a challenge for researchers to carry out the components of it. How will it help my research career?
I like to tell investigators and researchers that proper knowledge and compassionate implementation of the informed consent process is what actually evidence morally justifiable biomedical and health research practice. These practices ascertains that the researcher has permission to do the research study on humans who volunteer for the research. It ensures that the participants know enough about the study and what will happen to them during the study. It also allows the competent participant to make a decision whether or not to participate in the research, when or how to quit if they don't want to do it anymore. It also makes the difficult task of research, to say the least. Research with humans is a difficult activity, but it does help make it a useful collaborative experience that can benefit researchers and volunteers and society at large. I'd like to close with a statement from Dr. Henry Beecher, who I told you in 1966 looked at 50 unethical medical research studies and concluded that only 2 of them actually admitted to asking for and getting consent. He says the only true protection for research subjects comes from an intelligent, informed, conscientious, compassionate, and responsible investigator. It is my hope that anyone that's viewing this get that we need to do this, and we need to do it compassionately and conscientiously. Thank you for the opportunity to have this discussion with you.
Yes, thank you for this valuable talk about it. And I hope that all the viewers who are watching this will send any questions or comments about it, and I will forward them to Dr. Sodeke to continue the discussion about it. And I want to thank you so much for participating in this today. It's been very informative.
Thank you.
Thank you for watching this Health Research Talk. We encourage you to email us with any questions or comments. Also, please take a moment and complete the brief survey on the link on your screen. Let us know what you thought about it and how we can improve it for the future. Lastly, register on the NRMN website to sign up for the online mentoring and be a part of NRMN, the National Research Mentoring Network. Thank you.